I have balanced the camera on my high risk book. I've never opened it. I was wondering if it can stand vertically and balance a phone, and it successfully can. Previously, I was balancing on a water bottle and it fell, so my live got cancelled by me. Okay, so we are going to discuss the endometrial hyperplasia and the endometrial today, and I was telling you guys that endometrial hyperplasia is so worrisome because we have the risk factor for CA, and a very common issue these days is PCOS. That's why, which leads the patients to having endometrial hyperplasia. That's why I was telling you that for the patient benefit, make sure that your PCOS patients who are coming to you, make them undergo a withdrawal bleed. Okay, but please, guys, it's very important that you make the endometrium shut. Otherwise, their hyperplasia can turn atypical, and that can lead to a CA. Okay, even some questions regarding PCOS. Can someone tell me about the? Okay, we know the FSH-LH ratio. What is the most sensitive biochemical marker for PCOS? I'm asking about the biochemical marker for PCOS. It is, you have to talk about the biochemical hyperandrogenism. So you have to calculate the androgen, the free androgen index. So you have to check the serum testosterone level. Very important. Okay, next question is that what happens to the serum prolactin level? This is very important to recall. These things are increased in PCOS. अब PCOS की बात कर लिया तो what increases in PCOS? AMH. What else? AMH increases, prolactin increases. Okay. What decreases? Sex hormone binding globulin decreases. Okay. I don't know if I have an empty page anymore. Okay. So let's talk about the hyperplasia now. Okay. So the endometrial hyperplasia is of two types. Is going to be either typical or it's going to be atypical. The typical one is not high risk because the risk to cancer progression is 5% in 20 years. Please remember this. This is a question, okay? 5% in 20 years, the risk of progression to CA. So not very high in case of typical. So can someone tell me that what is the management of typical hyperplasia? Exactly. There are three management options that you have for typical. The first one is that you can just do an expectant management, that is, you can just observe because there is a chance that it's going to regress. Okay, regression can be there. Then you have the option of medical management, which is more suitable because mostly endometrial hyperplasia, it shows as postmenopausal bleed or some irregular bleed, and that's the symptom causes the patient comes to. The patient is not going to come to you and say, "Hello, doctor, I think I have typical endometrial hyperplasia. Can you please treat me with intrauterine system? Can you please treat me with Mirena?" No. The patient is going to come to you with postmenopausal bleed. Then you're going to perform a TVS, and then on that TVS, you're going to see endometrial hyperplasia. Then you're going to take a papal biopsy, and in that biopsy, you're going to find out that the hyperplasia is typical. And then for this typical hyperplasia, you're going to treat it. So now, please, can someone tell me what are the medical management options for this? I will be very disappointed if you don't know the answer. I'm running out of neat pages. So what is it? Exactly. I think I should put the notebook like this so that it's better focused. Yeah, like this. Okay. So what are the treatment options? The first one, the best one, is Mirena. That is levonorgestrel intrauterine system. This should be your first choice. Please remember. Okay, because why is it so? Because the hyperplasia, it's very simple. The answer is very simple. Can anyone tell me why is it the best one? Yes, because it's coming in direct contact, okay? It's coming in direct contact with the endometrium, directly releasing it on the endometrium, reaching it in the highest concentration, had the greatest effect on it. On the other hand, if I give the other option, this is the star, okay, the first one. The other options that we have are oral progestogens, which include the medroxyprogesterone acetate, 10 to 20 mg, and we can also include the norethistyrone. So this medroxy is, these are given for 6 months. Remember, 6 months. Okay. Now, my question to you is that what is the third management option? The third option is surgery. So, when are you going to resort to surgery? When the bleeding is a lot, if the postmenopausal bleeding is not responding to medical management due to symptomatic reasons, the patient's family is complete, the patient is insisting on it, and the patient is refusing the medical management. Otherwise, surgery is not the treatment of choice. It is a treatment of choice in, I have ran out of pages, guys. Why you just got done it. Wait, let me just get some more pages. Need pages. Okay, guys, this is my pathology. No, but I think I can use this. I can use this. Still gives me PTSD, these pathology diagrams. I can simply use this, okay? It's a nice notebook. Okay. So what was I talking about? I'm sorry, I should have. Okay. So I was talking about the management of endometrial hyperplasia, that if it is typical, then the risk to cancer progression is 5% in 20 years. And you have the option of observing it because it regresses. You have the option of medical management, in which Mirena is your first line. Then you have the option of surgery, which is not you don't go towards the option of surgery. Then what I was saying was that I think I should use a thinner pen. This is Sharpie is not, yeah, this one. Then what I was saying was that I have kept Mirena, okay. I'm the patient is not willing for Mirena. Guys, let's just speed up. So the first question is that the first line management for endometrial hyperplasia that is typical is Mirena. That is LNGIUS, but the patient has refused. What is your next option? Next option is oral progestogens, which include medroxy and norethistyrone. For how long? For 6 months. Now, you have given this treatment. How are you going to follow this? The patient comes to you, her first visit with postmenopausal bleed. You do a TVS on which there is endometrial hyperplasia. You do a pipel that is typical. This one. You are inserting a Mirena. What are you going to do now? You are going to, after 6 months, you're going to repeat the biopsy. Okay? And then after 6 months, you're going to repeat. So 6 monthly follow-up is going to be there for please understand it, because then I'm going to compare it with the atypical endometrial hyperplasia. So 6 monthly follow-up is there. And very important thing that you are going to look at the results of 1 year. What are the results of 1 year? Okay. So 1 year has passed. Her first visit, then after 6 months, then after 6 months. So how many total biopsies? Can someone tell me how many total biopsies have we done in 1 year, guys? 3 total biopsies, okay? The first one was for the diagnosis. The second one was for the follow-up. The third one also was for the follow-up. Now, if on 2 consecutive biopsies it regresses or becomes negative, then you're going to discharge the patient. You're going to ask her to go home. No more 6 monthly follow-up. But if it doesn't regress, you're going to keep on doing 6 monthly follow-up. Now, please listen to me. We expect that in 1 year, it will regress mostly. This is expectation because it's typical. It even regresses with simple observation. So we have a lot of expectations from typical. We are thinking that it's really good. It will listen to us. It's really obedient. So even if you just observe it, don't do anything, it will regress on its own. We're doing the Asian parenting. Okay, we just expect it to listen. But when we're giving medication, then we expect it to regress with a greater chance. Okay, so if it's not regressing after 1 year, or if it's progressing, or if it's relapsing, then in all those cases we're going to do a hysterectomy, because you say that medical management has failed. Let me draw it again. What I mean is that you have 1 year has gone by in which you have just the diagnostic biopsy, then after 6 months biopsy, then after 6 months biopsy, and in that the cases it has not regressed, or it has progressed, worsened, or there is excessive bleed, and the patient is symptomatic, the patient is willing, then in these cases you are going to do a hysterectomy. So you should know the indications for hysterectomy in a typical one, because they're very, very crystal clear. This is not our first choice over here. And if there are 2 consecutive negative biopsies, okay, one is negative and the second one is negative, and the 2 consecutive negative biopsies, negative, this means that now you are clear. You are discharged from the follow-up. Now, can someone tell me a very important recall, which two patients are not discharged from follow-up? Very good. The first one are the woman who has the BMI of 35 and above. And the second one is the woman who is on oral progestogens. Because what was our first line treatment? Please answer timely so that we can. What was our first line treatment, guys? Our first line treatment was Mirena. The patient is not taking Mirena. Instead, she's taking oral progestogen. So it's not going to be as much effective. So we're going to keep her on the loop. How oftenly? We're going to do an annual biopsy. When these are negative, discharge from the follow-up, but if these 2 cases are present, raised BMI, she's fat, or she's on oral progestogens, and in these cases, you're going to do an annual biopsy. So, yearly follow-up. So let's draw the algorithm for it, guys. I highly recommend you guys drawing your own algorithms. When you try to memorize the algorithms in the guidelines, you just try to mug them up and you don't understand them. So draw the algorithm with me. So this segment of today's class is called Draw With Me. So please take your pages and draw with me the typical endometrial hyperplasia. Endometrial hyperplasia, typical. A woman comes to you, okay, you're gonna do having postmenopausal bleed, you did a TVS, you did a PEPAL, This is the diagnosis. So the first biopsy is done for the diagnosis. What do you put her on? Mirena. Excellent. First choice. Mirena. If she refuses, then oral progestogens. Okay, you also have the option of observing. Okay, then when is the next? This is the first biopsy. The second biopsy is going to be after 6 months. The third biopsy is going to be after 6 months. You're going to see the whole performance of this in 1 year. What happened? What happened in 1 year? Whether it regressed, whether it progressed, whether it relapsed. What happened over 1 year? Now, if the two consecutive are negative, this one is negative, this one is also negative, two consecutive, then you're gonna DC. Go home, stay happy. But if she is having two things, what are those two things? Someone please tell me. If she's having two things, you're not gonna DC her. What are those two things? If she is having a BMI more than equal to 35, or if she is on oral progestogens, these are the culprit. You are going to do an annual follow-up. तो जब तक ये एंडोमेट्रियल हाइपरप्लेजिया ठीक नहीं हो जाता, फॉलोअप कितने अरसे बाद करेंगे? 6 मंथली. और जब ये ठीक हो जाता है तो फॉलोअप कितने अरसे बाद करेंगे? नहीं करेंगे जब ये ठीक हो जाता है. तो सिर्फ 2 कंडीशन है जिसमें फॉलोअप करेंगे ठीक होने के बाद. वो 2 कंडीशंस कौन सी हैं? वो 2 कंडीशंस हैं बीएमआई ज्यादा होना और ओरल प्रोजेस्टेरोन. इनमें फिर हम फॉलोअप कितने से बात करेंगे? इनमें फिर हम एनुअल फॉलोअप करेंगे. So the time for questions, answers, guys. Whoever is going to answer correctly is going to be today's star student. Okay. So my question is, question number 1. What is the first line or the treatment of choice in typical endometrial hyperplasia? My second question is, what are the indications for annual follow-up? My third question is, what are the risk factors for this? So please answer these questions in the comment section in the chat box. And then if you guys have any questions, feel free to ask. Thank you. It was a good session. I know we just discussed typical, but this is all the energy that I have. We'll discuss the later one tomorrow, I guess, in the next session. We'll discuss the atypical. I want you guys to read the atypical one and we'll discuss it. This session was good. You guys answered questions very well. But next session is going to be about the atypical one. This was a typical one, so please read up on that too, okay? It's the same guideline.